Hello everyone. At the outset, I would like to thank the organizing team of the Russian Society as well as the AWR Surgical Association for giving me this opportunity to present on universal COVID precautions. What are the new rules of the game? I, Vivek Bindal, bring greetings from Sir Gangaram Hospital, New Delhi and Clinical Robotic Surgery Association, India. So this is the situation of COVID-19 pandemic as of today from WHO. And you can see India as well as Russia, they are severely affected and there have been hundreds of millions of cases worldwide. If we see the numbers, India is second in the world in terms of total cases and touching almost 10 million, while Russia is fourth and almost 2.5 million cases. So whenever we look at a pandemic pattern of outbreak of respiratory illness, there are various phases. There is a phase of pre-pandemic interval, then there is initiation, acceleration, a peak is reached, and the deceleration comes in. So we are at different areas in this graph, depending on the region we live in, the country we live in, the state we live in, the city we live in. Everyone has a different situation. And accordingly, the practices have been modified. So we'll talk about the glimpse into Indian scenario, what are the recommendations for PPE, how to work up patients and protocols for surgery and robotic surgery or elective surgery and the vaccine. So, giving a glimpse into what we have right now at our hospital in New Delhi, the entry to the hospital is also segregated. So you see on the road which is leading to access to Gangaram Hospital, there's a banner which states gate number 1 for COVID patients and gate number 2 for non-COVID patients. And here you can see this is gate number 1, which is for COVID services, and this is gate number 2 for non-COVID services. So right from entry to the hospital in a car, the areas have been separated. Then these structures have been created outside for screening of patients at entry. So there is dedicated staff who is screening all the patients who are coming in for outpatient care. They're taking their temperature, they're looking at their applications, the Arogya Setu app, which Indian government has given for listing the risk status of an individual, as well as their history is taken and their appointments are checked. These also act as control points to prevent any kind of increase of rush inside the hospital. Then there are these green corridors which shows non-COVID emergency and OPD services, and the sanitization tunnels used to be used in past outside the hospital as well, which now is no longer used. There are separate lifts for COVID as well as non-COVID hospital. You can see this is green lift, non-COVID, this is COVID lift. So a lot of changes there. Segregated seating in OPD, so people would sit with social distancing. And a lot of work is being done by Reach Out branch, the home care. So a lot of services are being provided at home to the patients so that they don't have to come to hospital for each and everything. So in this pandemic, we have to divide our patients as well as the surgical procedures. So we know emergency surgery is there, then semi-elective and elective surgeries. So we need to prioritize the surgical priority of a patient depending on what kind of disease is he suffering from. And we also need to classify the patient into cohort A, B, C. So cohort A are suspected or confirmed COVID-19 patients. Cohort B are those who are in close contact with COVID-19 are into quarantine, and cohort C are which are proven without COVID-19. So patients who have emergency conditions, so patient cohort C, COVID-19 negative, you continue surgery as you do any which ways. Patients who are under quarantine, if the surgery is emergency, then any which ways it has to be done with all PPE precautions. But if it is semi-elective, you do further COVID testing, give some time, and if there is no infection, then continue surgery. And if there is confirmed infection, then postpone surgery for at least 2 weeks. And in patients in cohort A who are COVID positive, you only do emergency surgeries which are life-threatening. Elective or semi-elective will be postponed. And when you do surgeries on cohort C or non-COVID patients, you are wearing level 1 PPE. And when you're doing emergency life-saving procedures on cohort A or COVID positive patients, you are wearing level 2 or 3 PPE. This is what level of PPE would mean. Level 1 would include scrubs, surgical cap, disposable gloves, and surgical gown, as well as mask. Level 2, apart from this, also has a shoe cover and N95 mask. Level 3 has a respirator. So we see here, this is a picture from Dr. Ashwin Bawa, a dear friend, who is showing what is a level 1 PPE for OPD. It has a surgical cap, a face shield, a mask, scrubs, gloves, and a waterproof case for your cell phone. This is level 3 PPE inside the OT. This is my picture in this level 3 PPE, as well as a half face respirator with a face shield on and goggles on. So the goals of protection are, we need to protect everyone while we are transferring these patients to OR, in the OR as well, after operation, during recovery, and going home. So this is for protecting the patient. Also, we need to protect ourselves, we need to protect our co-workers, and also the families and the relatives. There is this concept of regional cooperation. As I said that, every region has a different pandemic phase. So we need to address the capacity of hospitals and the pandemic situation in every specific region separately. We need to maintain the supply chain of essential medical equipment to all the hospitals. Training and availability of healthcare workers is very important, which becomes a problem in this era. And COVID-19 tests should be made available in as much numbers as possible. So this regional approach is something which all of us need to look into, and we need to do it. Inside the operating room, we should have minimum number of personnel in the OR. Level 2 or 3 protection is required. Intubation risk. Intubation is a very high risk procedure for aerosol generation. So surgeons and personnel who are not needed for intubation should remain outside the OR when the intubation is being done. Smoke evacuation in laparoscopy and robotic surgery should be something which we should look at. We should not allow the smoke to escape into the theater. We should have either smoke evacuators or pass it through sodium hypochlorite solution into the suction machine. Minimize the use of electrocautery and ultrasonic devices. While now a lot of evidence has come up that surgical smoke is not causing COVID, so we are not a lot concerned about it. And minimizing the use of drainage tubes. So in minimally invasive surgery, laparoscopic suction is recommended to remove surgical plume and to deflate the abdominal cavity so that the gas does not leak out into the room. We use lower abdominal pressure if possible, and specimen extraction is performed with minimal CO2 escape, and minimize the blood and fluid droplet spread. So we tend to minimize the body fluid as well as the gas spread inside the operating room. This is our team doing minimally invasive surgery. You can see everyone is wearing PPE with face masks or respirators, and right from anesthetists to technicians, everyone has been taking all the precautions. So when we do a robotic procedure in this pandemic, you can see here the less number of bedside assistants are required. So here we are doing a hernia robotically. There is no bedside assistant because the surgery is going on well and the assistants can stand away. Surgeon is also himself sitting at a distance. So you can see I am sitting here operating while at least 2 meters distance from the patient, and any which ways it is a minimally invasive environment as well. So it gives us benefit of less number of personnel required as compared to even laparoscopy. So here we are doing laparoscopic surgery, and you see we are on the side of the patient, while in robotic you sit on the console without being very close to the patient. So again, coming back to elective surgery in these various cohort of patients, elective or semi-elective. For cohort C, who are negative, you continue with surgery. For cohort A, you postpone the surgery. And for cohort V, you wait for 2 weeks and then rescreen. Again, level 1 PPE for cohort A. So for all our patients, we do a travel history, symptom check. Arogya Setu app is the app in India, which is tracking the patient movement. CBC and CRP. COVID RT-PCR is mandatory within last 3 days, which is what is our policy in our hospital. And HRCT test if there is a suspected infection and COVID RT-PCR is negative. So this is a video of the surgery being done in, COVID era. We are closing the port. And now you can see everyone is in full PPE while they are operating. So the surgeon, the anesthetist, the assistant, the technicians, and minimum number of personnel are there in the theater. Now the vaccine is coming in. The Sputnik 5 from Russia was the first one to be launched, and Covaxin or Zydus are the candidates in India. Pfizer and Moderna from US and Oxford from UK. So this is bringing us new promise, and we hope that it will be available and effective and safe enough for us to avoid any kind of problems later. So the take-home message is adequate precautions are must in COVID pandemic. PPE testing pre-operatively, smoke evacuators, masks and respirators are the new norms. Elective procedures may not be postponed because of the pandemic unless in a particular region the pandemic situation actually requires so. Hospital has to gear up from entry to exit to prevent cross-infection. And with the vaccine, we hope to return to pre-pandemic era by the end of 2021. Thank you so much for your kind attention. I shall be happy to take any questions.